Hi, my name's Derek Angus. I am the chair of the corticosteroid domain for REMAP-CAP, and I'd like to just briefly go over some changes to this domain. By way of background, REMAP-CAP is addressing, broadly speaking, the question of whether corticosteroids help patients hospitalized with severe community-acquired pneumonia. This remains a question for which the answers are unclear. We have demonstrated benefit in severe COVID-19, but it's not exactly sure if there would be benefit in other types of CAP. There have been numerous randomized controlled trials and meta-analyses, but these results have been inconclusive. Some suggest benefit tending to be in sicker patients, but there are also adverse effects. And so some of the key unknowns that REMAP-CAP was already designed to address include, should steroids be given for CAP due to influenza? How should dosing of steroids be given if the patient also has concomitant septic shock? And what to do if the patient has not just CAP, but also ARDS? There are three other questions that we would like to embrace in the design. One is, which corticosteroid should actually be used? There's evidence for benefit with both hydrocortisone and with dexamethasone. It's also unclear whether corticosteroids should be given to children with severe CAP, severe influenza. And it's also unclear what to do if the patient is sick and admitted to the hospital, but not so sick they're admitted to the ICU and meeting the severe state criteria. And so we've implemented three changes to the corticosteroid domain. First, we've added a new intervention, fixed course dexamethasone. Second, where sites have got approval for the updated core protocol, the domain can now be open for patients in moderate state, i.e. patients who are not receiving organ failure support in an ICU at the time of enrollment. And third, we've extended the age limit down to 28 days. In other words, children, other than neonates, are now eligible for enrollment in REMAP-CAP. So the changes to the inclusion criteria are children from the age of 28 up through all of adult life. And if enrolling patients in the moderate state, there is one proviso, which is that they should not only be hospitalized, but they must be receiving some form of supplemental oxygen by face mask, low or high flow non-invasive ventilation, for example. The exclusion criteria remain essentially unchanged: known hypersensitivity to any corticosteroid, intention to prescribe systemic corticosteroids for a reason other than CAP, for the severe state patients if they've already been admitted to the ICU for more than 24 hours, and if the clinical team believes that participation in this domain is not in the patient's best interest. In terms of something about these arms, so there's now essentially 4 arms that someone can be randomized to: the no corticosteroid arm, the fixed dose hydrocortisone, which is a 1-week course of IV hydrocortisone at 50 milligrams Q6, also the shock dependent hydrocortisone, which is IV hydrocortisone also at 50 milligrams Q6, but only while the patient is in shock. These doses, these arms all existed before, and now this new arm of fixed duration dexamethasone, which is IV or enteral dexamethasone at 6 milligrams daily for 10 days, but with dose adjustment for pregnancy, and also in children, it is weight-based dosing. As always, if you have any questions, you can reach us at www.remapcap.org. Thanks so much.